Preterm labor in premature delivery. The preterm labor basically refers to labor occurring after 28 weeks but before 37 completed weeks, resulting in premature delivery. The preterm newborn is at risk of death because all its body systems, such as lungs, brain, digestive, and immune systems, are not fully developed. And there is increased susceptibility to infection and impaired clotting mechanisms. The baby is also at risk of birth injuries, such as cerebral hemorrhage, because the fragile cranial bones do not provide sufficient protection for the brain. Some risk factors for preterm labor include young age of mothers, poor socioeconomic class, and smoking. The causes are maternal infections, for example, pyelonephritis and malaria, and also incompetent cervix, premature rupture of membranes, multiple pregnancies, abortion placenta, and diabetes mellitus, preeclampsia or eclampsia. So the symptoms are regular and painful uterine contractions or abdominal pains, and there may be a show too. The signs that are usually elicited are small maturity, palpable regular uterine contractions, progressive effacement and dilatation of the cervix, ruptured membranes. Investigations are FBC, fasting or random blood glucose, ultrasound scan for those not in established labor. Also for gestational age, so fetal lie presentation, amniotic fluid volume, placental size, estimation of the fetal weight. So the main treatment objectives are to stop the uterine contractions if labor is not fully established, and to allow fetal growth and maturation in utero, that's in uterus if possible or if feasible, and to promote fetal lung maturity as its gestations 28 to 34 weeks, and to allow labor to progress if it is already well established, and to treat any underlying cause, for example, malaria, pyelonephritis. So non-pharmacological treatment: to avoid sexual intercourse, avoid strenuous physical activity, bed rest, cervical cerclage suture for cases diagnosed as due to cervical incompetence. For pharmacological treatment, tocolysis, we give salbutamol IV infusion 2.5 milligrams in 500 milliliters of dextrose 5%. You start infusion at 10 micrograms per minute, that is 2 milliliters per minute, and increase rate gradually according to response at 10 minutes intervals until contractions diminish, and then increase rate slowly until contractions cease. Maximum rates 45 micrograms per minute. You maintain rates for 1 hour after contraction has stopped, and gradually reduce by 50% every 6 hours. Maximum duration 48 hours. Or you can give nifedipine oral 20 milligrams initially and then 20 milligrams after 90 minutes. And if contractions persist, therapy can be continued with 20 milligrams every 3 to 8 hours for 48 to 72 hours as tolerated by the patient, with a maximum of 460 milligrams per day. So you monitor blood pressure, and you give magnesium sulfate IV 6 grams intravenous load as initially over 20 minutes, and then 2 grams infusion per hour. And after you give infusion, the infusion rate will be based on response. So for fetal lung maturation with antenatal corticosteroids, gestations between 28 to 32 weeks, you give betamethasone oral. So betamethasone oral, you give 0.6 to 7 milligrams every 24 hours. That's 2 doses. Or dexamethasone 6 milligrams 12 hourly for 4 doses. Treatment is most effective if delivery occurs at least 24 hours after the first dose of the medicine has been given, and less than 7 days after the last dose of the medicine. So avoid dexamethasone or betamethasone use when infection is present. There's dangers of steroid use, including susceptibility to infection could occur, and also fluid retention and pulmonary edema and maternal postpartum collapse may also occur. So you have to avoid dexamethasone and betamethasone. Referral criteria: treatment is best done in the hospital where the facilities can support and adequate care of the preterm units is ensured. So therefore, you refer the mother if the clinic cannot adequately care for the immature unit, and it's better to transfer the fetus in utero to the referral center.